Yeah, that is true though. It's interesting that that's
Yeah, I've actually got like some of what she says.
Uh-huh.
So her name is Stephanie Joyner, and she teaches Christian childbirth education. And she gives, like I said, she has really good meditations, and she also has good blog posts where she's blogging about birth from a Christian perspective. So she says, she goes through the story of Genesis, and then she talks about how the first thing that happens when Adam and Eve disobey God is they're given a curse. And the curse says, he says to Eve, "I will intensify your labor pains, and you will bear children with effort." Interesting that here he says intensify. It was already intense. That's pretty much it. As far as one-liners go, this is a pretty powerful one if you're a woman. It leads to a myth about Christian childbirth, which is that it's all about the curse. The language alone conjures up thoughts of an evil witch with a bubbling cauldron casting an evil spell that cannot be escaped. And while it's not exactly a spell, we often treat it like that. And she says, is that the best we've got? I say no. And she said that the devastating effects of Adam and Eve's sin were very real and very painful, and they go far beyond making life a little bit harder. The most devastating effects stained our souls, not just our bodies, and this is why our hopefulness in life must be anchored in the work of Christ and his redemption for our souls. But she says, now back to the garden. If you keep on reading, you see that Adam gets a talking to also. Do you guys remember what does God say to Adam after he eats the fruit?
Yeah, working the ground, thorns and thistles, and I mean, labor, basically like physical labor.
Yeah. So similar language is used, cursed and painful labor. Like those words that are used for both Adam and Eve. But it's interesting. She says he is laboring. Labor is just that, hard work. She says, how did birth and farming end up with such perceptions? She says she kind of imagines this Amish guy, and this is purely imagination. He's got a straw hat and suspenders and muddy boots and sweat on his brow and probably some gnarly pit stains, but he's laboring, and in it there's something beautiful and redemptive. Like when we think of the fruit of our hard work on earth, we think of it as something redemptive, but when we think of childbirth, we often think women just need to grin and bear it. But she's making the point here that labor is beautiful and redemptive, and there's joy and beauty in it, just as much as there is in Adam. And sure, it's difficult. It is, now we live in a broken world, and things can happen. But just to think of birth as something that it can be safe and peaceful and hopeful and grounded. I mean, both in an emotional sense and in a spiritual sense too. So I'll send her writing to you. I just find it really interesting.
Yeah, that's interesting. It does feel good, like after a hard day's work, you're just sitting back and like that felt really good. It was hard, but we got something done. But yeah, it's interesting to compare it to giving birth.
Yeah. Although I guess the reward is your child.
Yeah, that's probably a bigger reward.
Yeah. I remember after the birth of both my kids, I felt like a warrior. I mean, I felt like the strongest, most powerful thing ever. And I was just like, I did that. And there is this beautiful, glorious reward, this happy baby, but there's also this like joy in the effort that it takes. I mean, it is literally a labor of love to get that baby. So. And for the sake of time, we probably won't do it now, but I'm handing this to you to put in your notebook. It's some meditations on scripture, and great to use when you're pregnant, but also she gives some ideas for using scripture and relaxation, in the moment of birth.
Thank you. So
my encouragement in that is to worship while you wait. This is kind of a hard season of waiting, you know, and at times it's gonna feel like it's taking forever, especially as you get bigger. Just remember, as you prepare, not to listen to the voice of fear. And remember that, you know, the same Lord who took that baby in your womb and is growing that baby step by step, he is also the one who is holding it, and the one who is going to be there with you in the birth room through everything.
Mm-hmm.
So, and I hope having that peace and that comfort quietens your soul.
Yeah, it's a neat ministry that she did. Coming up with those meditations.
Yeah, it's really interesting. I love to bring the spiritual into the birth teaching process when I'm working with Christians. I think we have kind of different perspective on it. So yeah. So this week is all about comfort measures, and but there's some things we didn't finish from last week, which is kind of more of the medical side of things, just routine interventions, like things that normally happen when you're in a hospital, and also some pain relief options that you have, like medical pain relief options, talking through the benefits and the risks. So I kind of want to see where you're at with this, and why don't we start with fetal monitoring, because I know you said you had a conversation with your provider, and she said that you were able to walk around freely in labor, which makes me think that they don't do continuous fetal monitoring.
Right, as long as you're not on a medication that needs to be monitored.
Yeah, okay. So if you get like a Pitocin induction and then you have an epidural, then you would be certainly continuously fetal monitored.
Right.
So you're a nurse, which is great. You kind of have this inside scoop on things. You've seen how the fetal monitors work.
Right.
They have like a belt they strap to your belly, and it's got this thing, and they put it on, and it just, you hear the whoosh, 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 whoosh.
Okay.
You hear the heartbeat. So it,
Interesting.
and that's because if there's any sign of fetal distress, the baby's heartbeat is gonna start getting lower, and that's when they know they need to do something.
Okay.
So it's most common that they do it intermittently, so maybe once every hour, a couple of hours. It really depends on the provider, how often they do it.
Okay.
And it can be a little bit restraining if you're walking around and then you have to sit there and have them monitor, but it's how they monitor and make sure that everything is going smooth.
Right. Okay. So then the medication, is that like, if they give you medication, they just want to make sure that it's not affecting the baby?
Yeah.
And so this is completely small. Okay.
Because all medications do cross the placenta, like all medications that they use in labor and birth. So there's different risks in mother and baby, and so they would know the baby was in distress or something if the heart rate were to get slower.
Okay.
And the heart rate does kind of speed up and slow down, and that's normal. But they'll be able to tell you, like, if the heart rate goes below this number, then that's a sign of fetal distress.
Okay.
So I wouldn't worry about it. It's not that common, but it's just good to know what that's for.
Right. Okay. Cool.
Yeah, and if for some reason they do put you on continuous fetal monitoring, like let's say you get there at a funny hour and your provider's not there, and the nurse wants to do continuous fetal monitoring, but you want to use gravity and you want to use some of the comfort measures that you planned ahead of time, I always tell my clients a really good thing to do is go to the bathroom. Because then you'll get back in bed and you'll put it back on, but you at least have some time, get up, walk around, use the bathroom. Sitting on the toilet is like an excellent position. And it gets things going a little more. So remember that if you ever need it, just use the bathroom.
Take your time. My wife's constipated, I'm sorry.
So another one is labor induction. So Janine, do you know some of the methods that they use of labor induction?
I just know Pitocin. I don't really remember anything else.
Okay. There's actually several methods, and they all carry their own different benefits and risks. Pitocin is definitely the most common, and that is basically synthetic oxytocin that they're giving. So that hormone that triggers labor and strengthens contractions is just the synthetic form. The difficulty of that is it can make contractions extra strong, and so pretty much everybody that gets Pitocin also gets an epidural. And because of that, you know, if you get Pitocin and you get the epidural, now you have to labor on your back. So it takes out some of the comfort measures if you are trying to do it that way.
Okay.
Yeah, as far as Pitocin goes,
And they would give that, as a monitoring, like, the centimeter per hour, right? Like, if it's not.
like if you have failure to progress,
Failure to
like
progress,
the time limits, they could. They could give it, they could induce, so different circumstances that you might face in induction is, one is failure to progress, if they think that labor is going too slow, or, you know, if Janine feels like labor is going too slow, and they could use that to augment it and actually just speed up the labor. They could also do it, let's say, if you're overdue. It is normal for a first-time mom to go up to 42 weeks without having, you know, bad outcomes. But most providers won't go over 41. So if you're overdue and the provider's getting uncomfortable with the time and you're ready to get things started, they might give you Pitocin. But it's not good to give Pitocin before the cervix is fully ripe, because it could not be effective, or, well, it will get things started, but often it just starts a whole cascade of interventions. And so usually, sometimes what the first line of defense that they'll do is they'll give something like a prostaglandin gel. The prostaglandin gel, prostaglandins soften and ripen the cervix. And often that's enough. And so with one of my own births, I did that. And so they can insert it, like put a pill on the cervix. It kind of ripens it. So sometimes they'll have multiple forms of induction that they'll have to do. The truth is, if the body is not ready, then the body is not going to respond really well to an induction. So there's the prostaglandin gel, there's the Pitocin, there's also like a balloon Foley catheter.
Oh,
They can do, yeah. Did you ever see one when you were in your L&D rotation?
No, I just heard about it.
Oh, okay. It's, yeah, that one's interesting. They put a catheter in, it has a little bulb filled with water, and it kind of manually dilates the cervix, and then it falls out when the cervix gets to about 4 centimeters. So that was kind of the routine thing in the hospital I was in South Africa. It was one of the more common inductions. I don't know how popular it is here. That's a question for Dina. Yeah, so those are some different types of inductions and different times you might need them. You know, if anything, for instance, if some sort of complication were to develop, like preeclampsia, that might also be a time that they would induce. So we hope that doesn't happen. And also, have you guys heard of natural things you can do to get labor started?
I've just read about like physical things, like I don't know, squatting and stuff. I don't know.
Well, tell me, what are some of those kind of things? Let's say
Squatting, I think some people say you can eat certain things, or I don't know. Just from what I've read online.
Yeah, and there's like all sorts of different different wives' tales out there. I don't know how many of them are true. But you know, let's say you're getting overdue and doctor says, okay, you're 40 weeks and 3 days, but on Friday we're going to induce you if you haven't gone into labor. And you're like, oh, I don't want to get induced. So you try some natural things. First of all, the most effective thing, this is proven, so this is not just like eating spicy food, is
Okay.
sex.
Oh, really?
because semen contains prostaglandins.
That's
Oh,
so
wow.
funny.
That's
Yeah.
really interesting.
So from like 38, 39 weeks, just do that a lot. It gets really difficult at that stage, but it's the best thing you can do for your cervix.
Okay.
That's so funny.
That is interesting.
Wow.
Yeah.
Huh.
Another thing is nipple stimulation. You might want to ask your provider about this because it actually can bring on pretty strong contractions, and you don't want to do this too early. But if you're overdue, like you can look it up how to do nipple stimulation. Just kind of like rubbing your nipples, touching your nipples, almost as if a baby was breastfeeding on you. And it stimulates the release of oxytocin. And so that sometimes is enough to kind of start things. And then of course there's all the positions, movement, walking, that just can especially help get babies in the right position to prepare them, because you need the baby to engage in the pelvis, before labor is going to begin. And there's a lot of other things out there too you can try, like Caroline swears by grapefruit skins. And I don't know anything about this one, but she says this is what someone told her to do in the States, and she boiled a bunch of grapefruit skins, and then she went into labor that night. I'm like, well,
Wow. So she drank?
yeah, she drank it.
The juice, like from the skin. Wow.
Yeah, ask her about it. I've never heard of that method, but there's lots of things in nature we don't know about. So
That's true.
if semen contains prostaglandins, I'm sure there's chemicals and things in certain foods that probably are effective, but most of those are safe to try. So always, if you're going to use something herbal, then that's when you definitely talk to a care provider, because even herbal things can be harmful. So I don't give any medical advice. I just say do your research, talk to your provider, but know that there's natural ways to get things going. So
there's probably an essential oil out there.
yeah, essential oils that do everything.
I know.
Yeah, so do you guys have any questions or want to hear more about, because I can always go in more in depth, but I also don't want to overwhelm you with information. So about induction specifically.
Do they give you Pitocin at like a certain time, or is this like right from the beginning if you're not progressing? I don't know, within the stages of labor, like.
Well, it depends on if they're trying to augment labor or
Like
start labor.
labor.
So if they're trying to start labor, I think they'll start a drip and they'll do it a little at first, and then increase the dosage a little bit. Yeah, it would depend on the situation. And that is something that you can have in your birth plan. Under what circumstances might you want that, or you can have it in your birth plan. I would prefer to try such and such methods first.
Before.
Okay. You're not saying that I'm not going to get it, but you're saying, well, what is your preference? If you'd like to start with a prostaglandin first, depending on your cervix.
Yeah. Okay. Yeah, that's good to know.
Yeah. What about you?
And so you said they might want to induce you at, like, they wouldn't let you go to 42 weeks, or it just really depends on?
It really depends on your provider. So if you go to more like a birth center, then they're going to be okay with you going probably up to 42 weeks.
Okay.
As long as there's no comorbidities, as long as there's no any problems going on.
Okay.
The risk of a baby going past their due date is that they could swallow meconium. It's when they have a bowel movement in the womb, but then they swallow it, and so that could be a problem. But then they're gonna check the heartbeat, and they're gonna make sure there's no fetal distress. So if there was fetal distress, they would definitely take action, whether it be induced or a C-section.
Okay. Okay.
Yeah, a lot of babies go to 42 weeks, and it's not a problem. But that's gonna be between you and your provider. I don't think they'll let a baby go past that.
Yeah.
And by that point, you're like, get it out.
You don't want to go past that.
But you do get some providers that are like, oh, we're 40 weeks and 2 days, let's induce.
Oh,
yeah, okay.
you know, and you're like, my cervix is not ripe yet, and you know, and that's where you can have it in your birth plan, what your preferences are. You know, so, and some people are gonna be like, I'm 40 weeks in one day, let's get this baby out, and other people are gonna say, yeah, but that's not the way that I want birth to go, so I want to wait longer. We do get something called this cascade of interventions, meaning when you have one intervention, like Pitocin, now you need an epidural. And because you need an epidural, now you need continuous fetal monitoring. And because you need continuous fetal monitoring and you can't go to the bathroom, you also need a catheter to drain your bladder. So you make one decision, which is Pitocin, and you end up with, you know, all these other things, and you're, you know, you were hoping to be able to walk in labor, but here you are, and you can't. So we, as much as we can, we try to stay hands off. We want women to feel, unless that's their preference, that the cascade of interventions doesn't happen, and then that cascade could result in a C-section. Because with each intervention, you do increase your chances of getting a C-section. So it's good to know, like, different things, like we talk about epidurals, what can happen in that cascade of interventions, but also under what circumstances could that be useful to you? Could that be effective? So we talked a little bit about pain management, but I wanted to go a little bit deeper into pain management and your choices. Most of the time today is going to be spent on comfort measures of what to do, like without drugs, using movement, using breathing, and all these things. But I also want to talk about your options for pain relief. So epidurals, what comes to mind when I say epidural?
So wait, this is when they stick a needle into your back, your spine. Oh really? Wow.
Yeah, I have a picture in there if you want to see how they do it.
Like right into this space.
Right, like that.
In between the vertebrae.
And then blocks.
Okay, so anything lower down.
Yeah, so then it's harder to like feel.
Wow. And you can't walk with that point, I guess. He's kind of like paralyzed.
Yeah. So this is probably the highest form of pain relief because if done correctly, when you get the benefits, you can't feel anything. So you also can't feel contractions. So it is effective at pain relief, you know. And hopefully you'll still be alert and able to push when the time comes. Because there's actually different types of epidurals, but one of you're able to kind of turn it down or turn it off so that when the pushing comes, you need to be able to feel it to push. If you can't, then you do directed pushing, and that's when they're looking on a fetal monitor to see when the contraction is coming through what they're monitoring, and they'll tell you to push. But we'll get to the pushing part in a little while. But yeah, so one of the benefits is that if a patient is so tense they can't relax enough to progress labor, because of tension or exhaustion, it can help with calming and so that they're able to progress. It also lowers blood pressure, so in patients that have high blood pressure or preeclampsia, it can be effective because it will lower blood pressure. Some of the risk is you can actually get hypotension, low blood pressure, and a fever, and it can prolong the first and second stage of labor. So it is, I don't have the numbers with me on average, but how much longer it can make things. Because you know, with this positive feedback mechanism that we talked about last week, where the pain is actually encouraging progress. So we're kind of interrupting that. Sometimes pain relief is inadequate. They might need to replace the needle, or it might just numb on one side. Sometimes it can create a feeling of detachment, so you just feel spacey. Some women don't like that. Some women probably want to be spacey. And then probably one of the biggest thing is, you know, it just that it kind of restricts you in what you're able to do. It restricts you to bed. So as far as for the baby, the risk is that it could cause respiratory problems and feeding problems. Like the baby, since medicines do cross the placenta, the baby can be a little bit more sluggish at birth and a little bit harder to breastfeed. And in some cases, though it's not super common, they can have respiratory problems. Yeah, so how do you guys feel about epidurals?
I think, yeah, I would want to be more part of the process. I think my mom had one.
Yeah.
Yeah, but definitely not my first choice.
Choice, yeah.
Yeah. Yeah, the risks don't sound really good.
Yeah, yeah. I mean, I know women that have had them and were very satisfied with their birth experience, but they weren't going for natural labor in the first place.
Right, it depends on what you want.
Yeah.
Yeah, I mean, yeah, I guess different women have different pain
Yeah, I don't want a
tolerances
catheter.
and
I'm
pain experiences.
inserting them bad enough.
Like, I have to do that enough.
What to be done to me.
No, I really don't.
Yeah, yeah. Oh,
Looks so awful.
I don't think I've ever had to have a catheter. Praise the Lord.
Okay.
I hear they're not so pleasant.
Yeah.
That's the only motivation, right?
Oh, that's a huge motivation. Yeah. Oh yeah, what are the risks with Pitocin? Like if it on the
The risk on the baby for Pitocin.
Yeah.
So it does, like I said, it can create kind of strong, intense contractions, and it can cause uterine hyperstimulation, which can cause fetal distress.
Okay.
That would be a risk.
Okay.
So again, if you're on Pitocin, they're gonna monitor you very closely, that baby's heartbeat very closely.
Alright, so
yeah, I mean, I need to make sure I'm not missing anything there, but I think that's the biggest risk. Another form of induction is misoprostol, which is it's actually the abortion pill. It's that little white pill.
oh yeah, isn't that what they give to women when they're having a miscarriage? Like end it.
Or aborting.
Or, yeah.
But they give it in smaller doses to women in labor to induce. And that can definitely cause uterine hyperstimulation, and in extreme cases it can cause the cervix to burst, which could cause death. It's not common, but it can happen, and most people aren't told of that risk. So,
And I already have like low blood pressure. I think it would tank pretty quickly.
oh, do you?
Well, I mean it's not like super low, but it's usually like 110, 115, like
Yeah, mine too.
there. So I don't know if.
Probably good for your provider to know then that they
Yeah.
wouldn't really encourage that method as much, I would think.
Yeah.
Yeah, so then the other form of pain relief is narcotics, like opioids, which basically is akin to morphine. Lots of variations of morphine. And they give this, sometimes they give it as a drip, and sometimes they give it as a shot in the leg. And it's...
Yeah, you have a nice long list here.
Oh, okay, great. If I don't cover anything, read it in the book that I've given you. But that can make you feel, it can definitely help relax women that are very, very tense and can't progress then because they're holding back because of tension or fear. It can help women sleep in labor. Like if you've been in labor for days and you're not sleeping and now you're too exhausted. They just don't want to give opioids after 7 centimeters because they want it to wear off before the pushing stage. It typically lasts for about 4 hours.
Gotcha.
So the good thing is you can have it and then it can wear off and you can continue with your labor.
So you'll still feel like the worst part of it.
Yeah. Yeah. It's basically if that like first stage is like super, super long and you need some respite. And there are risks associated with that as well that you'll see, but for a lot of women it causes nausea, so they'll have to give like an anti-nausea medication, and it can just create this really spacey feeling, which some women don't like.
That sounds bad, especially when you're like hungry.
spaced out and hungry.
Yeah.
Yeah, unless you're just gonna sleep and sleep through it.
Sure.
So yeah, that's one option. You know, it could be used in circumstances when like you are, you know, you need rest and you're, you know, for whatever reason can't relax. But the risk is also the main risk for the baby, and that one is also respiratory problems.
Okay.
And sometimes jaundice as well, because the, you know, their liver is having to excrete the medication after birth. So the baby, if you get narcotics during labor, even a few days after the baby is born, it can be very fussy and difficult to breastfeed.
Oh.
Any questions?
No, that's a good overview.
And there's no chance of the baby becoming like addicted to drugs at all, right?
No, I don't think so.
That's just continual use, I guess.
Right. I've never heard of that in like one time. I mean, it does affect them, you know, because your baby's getting everything you're getting. So there is an effect, but I don't think it's a dependency.
Right. Okay.
Yeah. Good questions. Adapting to circumstances. So it's important to know, like, you're going to go into this and you have your birth preferences or your birth plan, whatever you choose to call it. And I'll just go ahead and tell you, it never happens exactly according to plan. Maybe in rare cases. And that's okay. And, you know, there are things you can do to help adapt to circumstances. So for example, if augmentation is necessary, maybe their first thing to go to would not be Pitocin. It might be to sweep the membranes or break your bag of waters if your bag of water hasn't broken yet. Then the head is putting more direct pressure on the cervix and it can intensify things. So yeah, changes in pain management might be necessary, but usually, like, if you have talk to your provider, there are options of ways to augment labor if it's abnormally long or you're exhausted. Breech presentations, that'd be one kind of abnormal circumstance. You know, if they know about it ahead of time, we'll do an ECV. You try all these funny positions and try to get the baby to move on your own. And doulas can do this, like give you exercises and stuff. My baby, Joan, was actually breech till 38 weeks.
Wow.
And I went in to have my ECV, and that's where they actually they touch your belly and they try to manually rotate the baby.
Wow.
But I went in that day and he had turned that morning.
Oh, wow.
And Chris has pictures of me with my head on the floor and my feet in the air, like trying to get upside down.
Oh, that's what you did before.
Yeah, I did.
Okay. It worked.
It worked. Most of the time, babies will flip on their own, but in like a small percentage of cases, babies don't. And most providers here in the States won't do a vaginal breech birth. That would be a reason for a C-section.
Alright.
Okay. So they would still recommend you try to like turn the baby around.
Yeah, they would try to do an ECV,
Okay.
and if it fails, then they would probably do a C-section.
Okay.
I think there are probably a few providers that do vaginal breech births, but I think it's a special form of midwifery training that we're just not educated about in the States. You know, there used to not be an alternative like the C-section, but now with medical care improving, I mean, it's improved outcomes for difficult presentations. And we will talk in just a minute about some positions and positions of the baby. Yeah. Any questions about things that could happen, things that you could foresee having to adapt to circumstances?
Well, the ultrasound showed the baby upside down today, so that was good.
Yeah.
Yeah, great.
We're not going to stay that way.
Yeah.
Yeah, he's gonna be moving all around until you get much later, 36, 37 weeks, and then they begin to kind of find their position.
Yeah, because there's not much space left. So. Yeah, I mean, I don't really know. I guess we can find out once we get there.
Yeah.
Yeah, no, I think, yeah, those were
precipitous labor is one that I did mention. This could be a variation of normal birth where it's abnormally fast. Baby in the car. Anybody? It can happen. It does not usually happen much for first time moms. But the important thing is you're prepared, and if it happens, you're going to know what to do.
Right.
Yeah.
So you talked about like being tense, and that's kind of slows the process down.
Mm-hmm.
I guess you'll probably go over some natural ways of untensing.
Yes. That'll be the rest of our time is talking about coping with pain and also relaxation. Because yes, tension, we talked last week about how contractions work, the release of oxytocin. But when you're in a fearful environment, those stress hormones go up and that oxytocin goes down. So we need to relax. We need to not fight contractions. Sometimes just like women are tense, they're out of fear, they're holding back and they're kind of physically fighting that muscle contraction. Maybe they're tightening up their pelvic floor muscles. And what it does is it slows the progress. Do you guys want to take a quick break and I'll pause the video and then we'll get started on some comfort measures?
Yeah, sounds
All
good.
right.